Welcome to Civil Discourse, a podcast where participants are free to share their ideas, empathize with other perspectives, and who intend to advance to a better solution to fix a societal ill. We will focus on topics that are particularly complicated. In a time where information is from sources more opinionated than ever, our mission is to find solutions and goals to accelerate the nation's progress with cultural impunity. I'm your host, Todd Furniss. We're back for episode 2 with Dr. Jim Denison. I'm really grateful that Jim has joined us for not one, but 2 episodes. He kicked off the initial episode kind of framing what is civil discourse and framed 3 recommendations on how to conduct conversations in civil discourse. You'll recall that this episode, this program is really designed to tackle some of our nation's biggest problems and do so in a way that is committed to finding good solutions. It may mean that one solution is not identified as the best, but a combination of solutions with from opposing viewpoints is the best. And Jim, you laid out 3 things for us in the last episode that you consider good guardrails. I'll try and repeat them. Freedom of thought and the comfort in expressing yourself. Empathy with the position of the other person and their point of origin. And then thirdly, an intent to find a better solution. So let me kind of see if I got that right. And then with that, we can kind of kick it off.
Absolutely. I think at the end of the day, when someone is finished with this podcast, not only do we hope they've learned something, as certainly I'm learning, even in this conversation with you now, Todd, and grateful for that, but also we're hoping for a proactive future. We're hoping for change. We're hoping for things to be different as a result. And so that's that third point that you're driving to. You have to have the first 2 to get to the third. You have to make yourself heard. The other person has to be heard. And then within that, you're both looking for commonality that's a foundation for a better discourse, a better, more civil outcome, a greater future. So if we go in with that intentionality in mind, we're more likely to have that as the outcome.
Excellent. So, Jim, your resume is vast and humbling and impressive, and I'm glad that there are guys out there like you who do what you do and work as hard as you do at learning so deeply about a variety of topics. You served on the board of directors for Baylor Scott & White, the largest healthcare system in the state of Texas. Led at the time by our good friend Joel Allison, who is another towering figure in healthcare in the state of Texas, and a fantastic and noble man. You started down the path of getting some complex questions at the board, and that led to your taking on a new role with regard to ethics. Can you talk about the evolution of that role and some of the questions you had to deal with?
Yeah, thank you very much for that. So Baylor Scott & White started as what we think of as Baylor University Medical Center. It was originally Baylor Memorial Sanatorium, I think was the first name, George W. Truett. Back in the early part of the 1900s, well-known pastor of First Baptist Church, Dallas, who said, "Is it not now time that there be a great humanitarian hospital?" And here's the point: one to which men of all creeds and none may come with equal confidence. And from then till now, that's been the mission of now Baylor Scott & White. And so we have been and still are very confessionally a Christian ministry of healing. At the same time, we embrace the opportunity of serving those of all creeds and none. That applies to our patients. That applies to our caregivers. That applies across the entirety of the organization. We have Jewish individuals that are part of even our governance, as well as our caregivers, Muslims, Hindus, those of no faith commitment at all. And so within the board context, there's always been a seat for somebody who would come in as kind of a theological ethicist, somebody who would help Baylor navigate medical ethics issues within a Christian worldview that at the same time was in dialogue with other creeds, other expressions, other ways of thinking as well, rather than being so doctrinaire and so insistent on one point of view as to be violating our mission. So there was, for a very long time, a very dear friend of mine, Dr. Bill Pinson, who had been an ethicist himself, a PhD in ethics, who was in that chair. So Bill was rotating off the board after a very long period of time, and that's when Joel thought of me as coming on the board and serving in that kind of unofficial capacity. And then when we merged with Scott & White, a board service at that point became a full-time job. To be on that larger Baylor Scott & White board, I did not have the margin to be able to serve in that capacity. So that's when Joel asked if I would take an official position as resident scholar for ethics. And I've been in that role now for the last several years, functioning in that part-time capacity as opposed to a full-time board, as would have been the case otherwise.
So arising out of that is an opportunity for me to describe two fun facts, one of which you know and one of which you may not know, that I write about in my book, The 60% Solution, that's coming out soon. And the first of those is that we've been talking about healthcare as a nation, if you can believe this, since John Adams. Mm. So John Adams actually imposed a tax on sailors because they were bringing back diseases when they had their transoceanic ship rides, if you will, or cruises or work. And he charged nickel, I think it was a nickel a month, which would have been a very expensive amount of insurance at the time. Mm-hmm. At the same time, what you do know, I'm certain, is that Baylor was actually the first to insure patients when they issued an insurance program for teachers in the city of Dallas. Mm-hmm. So is that still I know that Baylor may have 2 or 3 insurance companies, but do you recall?
When I was on the board, we were working within a self-insurance context, and that's part of why we were so interested in the merger with Scott & White, out of Temple, is we believed that their system was superior to ours. We felt like they'd been able to get to a better cost reduction, to a better scope and scale, and we thought a combination would serve both sides of the merger more effectively, and that was one of the drivers behind all of that. And it is for the very reason that you're suggesting right now. We are missionally at Baylor Scott & White anyway, as a not-for-profit, a ministry of healing driven to care for those not only of all creeds and none, but of all payment potential and none. About a third of our patients at Baylor University Medical Center can't pay. And so being able to provide insurance internally and a larger kind of socioeconomic safety net for those we seek to serve is really part of our mission.
So we're going to dive into this more in just a minute, but that statistic is really both important and gripping, that about a third of your patients can't pay. Mm-hmm. So I want to put that on the bulletin board for holding just a moment, and I want to come back to it. But one of the things that it seems to me is the case is that when we talk about health, what you're really talking about is serving somebody who is suffering. Mm-hmm. It's not really talked about often enough, in my view. I read a lot about primary care in the book, but it's not talked about often enough in terms of disease or healthcare problem prevention. And so the question becomes, if you think about it, when you're offering services to someone in need like that, it's a form of suffering. And the question then becomes, is it moral to profit by a clinician rendering services to a patient? Is that a moral thing to do?
It's an enormously important question. It truly is, Todd. And by the way, you didn't ask me to say this, but having had a chance to read the book, I will tell you that it really is terrific. It's not only a terrific overview of this, but it's got some solutions and some ideas and premises for the future that I really do hope everybody in healthcare will look at, and even those just concerned, which should be all of us, about healthcare as well. It's also very, very, it's written in such a way that it's really accessible and extremely well done. And I'm really grateful you've done that. It's been a labor of love for you, and I'm grateful to you for doing it. And as you know, a lot of what motivated you was this conversation that we're describing right now. I have a very dear friend down at Baylor University Medical Center, Chief of Pathology, who has for years said, look, we're not really in the healthcare business. We're in the disease care business. What we need to get into is the healthcare business. It's the old 80-20. I was shocked when I came on the board, the degree to which this is true, that we spend 80% of our resources on 20% of our patients and 80% of those resources on 20% of those patients. And if we could ever get out of the disease treatment to get back behind that and be more proactive, be in a preventive model, that's where we have to go. And we're attempting very intentionally to do this with accountable care organizations, with the kind of technology available to us right now, with patient monitoring, with patient diagnosis, with all sorts of ways that we can help disease before it gets worse. We can help patients before they become worse. All of that's behind this. So that has to be part of the conversation. But really, to your point, all of that aside, there's still probably going to be a case that we're never going to be so good at preventative care that people are not going to get sick and need treatment as sick individuals. Is it fair to profit from their sickness? Is it ethical when they really have no option? They've got to go someplace. They've got to get surgery someplace. They've got to get chemo from somebody. And so we all have this kind of opportunity, it seems, to take advantage of the suffering in which they find themselves. Is that a moral thing to do? Well, the other side of the question is it possible to provide such care for such individuals without the financial means that make it possible to provide that care? And so is it moral to come along and enact a world in which healthcare providers are not able to profit from delivering healthcare and therefore not able to be in the business of healthcare, and therefore there be no care for the suffering individual? Is the other side of the moral question. And there are ways really, I think, to kind of parse both sides of that discussion and try to get to a commonality where we can get to some place that's both fair for the provider and for the patient. That needs to be, I think, the place we try to drive.
Well, implicit in the notion, I think what I hear you say is that not making a margin on the delivery of the service would actually lead to a lower quality service offering, which then means we're not
mission.
Exactly right. I've heard that from many times. In fact, the first time I heard it was from a nun who was in charge of ethics at a Catholic hospital. So as you think through that question, I feel like the issue of morality is a seminal component of the decision around payment. Mm-hmm. In other words, you only want to encourage payment structures that reinforce moral ideas.
Right.
You don't want to create payment structures that enforce immoral ideas or that incent immoral acts. Is that fair to say?
Absolutely the case. And now you're driving in a proactive direction. That's part of what I like about your thinking, the way you're looking at this for a solution to the larger issue. Years ago, I heard a story about a fellow that got lost out in the middle of the woods and found a guy on the side of the road, and he told him where he was wanting to go and asked how to get there. And the fellow said, if I was going there, I wouldn't have started here. You know? Well, if we're starting at a bad place, it's really hard to get to a good place. So let's do a reset. Let's do a magic wand here for a moment. Let's blank slate this and let's create a structure, a financial structure, whereby individuals can afford to provide care, but do so in a way that is fair to the patient across the spectrum of healthcare, not only focusing on being paid for sickness care, being paid in a way that incentivizes, quite frankly, a continued reliance on sickness care, continued testing, continued hospitalization. If you get well, I don't get paid, kind of a thing. Let's not incentivize that. Let's incentivize the doctor to keep you well. Let's incentivize the system financially to keep you from having to get sick. Build in some means whereby we can get paid when we do have to treat you for your sickness, but not have that be the entirety of how we get paid, and certainly not the way we get incentivized to treat the individual. It's an incentive model that we need to change, and that I think we can change.
So on the one hand, it seems to me that insurance in this regard, not Baylor's insurance programs necessarily, but insurance generally has changed from the prevention of catastrophic financial loss when something bad happens to almost like a layaway plan for healthcare. And when that happens, it seems to me that we lose the relationship with our caregiver directly. It means we have a lot of people in the relationship with our caregiver, because when we go to the doctor, we think we're having a relationship with that doctor, but the reality is the insurance company is offering what I call commercial regulations or protocols that they will accept payment for. There's a state, federal, and local government involved. The hospital system itself may have its own rules. The practice may have its own. So you really get confused on who the duty of loyalty is to and how the doctor is really able to deliver services in a meaningful way with the patient really at the center of the conversation. And to me, the reason that's important is because I don't think human suffering is an objective truth to anybody but the individual suffering. In other words, I know in certain instances when I hurt. But also I know that when you hurt, I can feel empathy for you, but I can't really understand that in the visceral way that you do.
Right.
So all I know that when I hurt, it's not fun. And I want to prevent that from happening to you because you're my brother and you're my friend, and I want to care for you. So to the extent that we can move some of these tools and resources to the prevention model, collect data and encourage individual responsibility and support that individual responsibility, tools and like, then it seems to me that that's a good idea, and we should be supportive of that and create payment mechanisms that support that as well, because that's implicitly moral. Is that correct?
Absolutely. I could not agree more. Absolutely believe that that's right. And we have some models for this. It's not that what we're suggesting right now is something that is so foreign to the system that it's not a possibility to move toward. For instance, insurance companies for a long time have been providing rebates for safe drivers. They've been rewarding people for not getting in accidents. You can get a rebate on or lower health insurance issues if you don't smoke, if you don't drink excessively, if you get annual physicals, things like that. So let's push in that direction. Let's make it even more incentivizing to the patient and to the provider to be able to reward even financially, as well as to make some requirements in that context. Well, technology is our friend here as well, as you know. We have capacities right now we've never had before to be able to monitor health, to be able to monitor patients in ways that can be interventional before the disease progresses to this very difficult place. Quick examples of that: there are electronic pillboxes now. One of the top 5 challenges we have in medical care today is patients not taking their medicine properly. By some measures, some years, that can be the number 5 cause of death, depending on who you're looking at and how you're measuring, is patients not taking their meds or not taking them properly. Well, we now can monitor pillboxes electronically. We can know if the patient's taking the med and the proper med and at the right time. We have scales that can measure body mass index. This is a little grotesque, but we have toilets now that can measure body fluids in ways that send immediate information to care providers. And so we're getting at the front of a colon cancer or something such as that. So technology makes it easier to do this than ever. It's just the system that's behind. The system that, as you've been saying, so incentivizes the person not to seek treatment until the need is great, and therefore the suffering is great. And quite frankly, the reimbursement through the medical system is at a higher level as well. That's what we want to change.
There's a gentleman out there named Mr. Thompson, and I don't want to mess up on his name, but he's a radio personality. He's a fairly progressive thinker in the contemporary use of the term. And he has asserted that profiting from the rendering of services is immoral. Mm. I think that leads to a contention that we should have a single payer system and government rendered care. Right. And I struggle with that argument. I can understand how the argument might be made. But what to me it does is it discourages innovation. It discourages the quality of care issue. It discourages the evolution of care protocols. Is that your experience? I'm sure you had these conversations at the board level, and without betraying any confidences, how did you guys come out on that?
Well, first of all, we're where you are at that point. If you go to single payer, you're essentially going to something like a Canadian system, and the Canadian system is a 2-tiered system. There's a basic level of care provided on the single payer government model, but if you want more than that, if you want a knee replacement faster than 6 months, if you want a kind of chemotherapy that they won't offer, you just cross the border, you go down to the United States, or you have concierge medicine. You have a concierge experience that you're paying for. It'd be as though you're paying for private school, but your taxes are supporting public school. It's that kind of a model. If we ever get to a single payer model, that is what will happen. That's inevitably what will happen. If you take financial incentive out of the system, as we learned in communist Russia, as we see in communist Cuba, where I've been 10 times over the years, when there is no financial incentive, it's very, very difficult, in human nature being what it is, to incentivize growth, to incentivize progress, to incentivize competition, to incentivize the kind of innovation that's essential to continuing the evolution of better and better healthcare. It's a drastic mistake to remove that incentive entirely from the system, I believe.
It's the ultimate monopoly, right? Which is what we always try and fight against, I think, in our country, saying that that's unfair and unjust, and that the concentration of that power in a single entity doesn't produce good outcomes. We haven't seen it produce good outcomes, no, really. And what most people don't realize, and I've think I point this out in my book as well, is that in virtually every market where there is a single payer system, about 30 to 40% of that population has private insurance. And so what you're really doing is you're saying we're going to have a two-tiered system, as you pointed out with regard to Canada, and we're going to hurt the people who are already most vulnerable. The less advantaged of our communities are going to get the lowest quality service, as opposed to having them benefit from the investment and the innovation and the seeking to improve quality and reduce cost that comes about through the market mechanisms that we've become familiar with over the last couple of hundred years. I don't want to pretend that we can go to a fully free market instance of this. So let me just kind of put an idea on the table for you and see how this resonates. I believe that we do need delivery mechanisms that can accommodate the less fortunate in our society.
No doubt.
I think we need to have vehicles through which care can be delivered where the individual who is unable to pay still gets care. And that care should be the highest quality care that's possible. And we have tools like Medicaid present today. And what I'm going to tell you is a little bit, maybe a little surprising and aggressive, but I think that we got to figure out a way to bridge people from Medicaid into private insurance. Right now, what happens is, if you're in Texas anyway, where you and I live, if you make up as a family of four or a household of four, make up to $51,000 a year in household income, then you qualify for Medicaid. But I haven't seen too many people ask the question, what happens if somebody gets a raise? And now all of a sudden, the family or the household has to pay for their own health care, and that number is $20,000 to $25,000 on average for a family of four. So how do we address these kinds of issues where one solution doesn't work, but there's no bridge to a different solution? How do we get our heads wrapped around that? I've actually advocated indexing, where for every $1 somebody puts into an HSA, state and federal governments put in a MAC number so that you can build some value in that HSA that then allows you health savings accounts, that then allows you to be a consumer of healthcare. What are you seeing in your experience? Because I know you've talked about a lot about this with the board. What are you seeing in your experience that would be a bridge to another vehicle?
First of all, we need a bridge. There's no question whatever, as you say, about that, because we're disincentivizing individuals across the board, right? If it costs you more to live, to be off of welfare than to be on welfare, to be off of Medicaid than to be on Medicaid, well, why are you going to do that? Why? And therefore, we're having to support as a society individuals who could be producing, who could be productive in the culture, except we've disincentivized them by virtue of the very system itself. So what happens in the default? And people don't like to talk about this. It's not something that we're proud of. It's certainly not something we wish is the way it is. But for a certain strata of the public, the emergency department is their healthcare. They don't have a doctor. They go to the ED when they would typically be going to a doctor, when they would typically be in some kind of accountable care structure. They just wait till they're sick enough and they go to the ED. That challenge on several levels. First of all, we're not getting anything preventive done here. We're just dealing with the issue as it is. Second, that's the most expensive healthcare we provide. That's the least cost efficient way to care for a patient, is to see them through the ED or see them primarily in the emergency department. But that for a whole host of people that have aged out of financially a Medicaid structure, that's how they're getting the healthcare in this state and across a lot of the country. And that, again, is not sustainable. That's a lot of what's driving the cost of healthcare on the rest of the lanes on the freeway, because we have to make that money back somehow. And so those of us that are not getting treatment in this way are paying more than we should for the sake of those that are getting treated the way they are, because the system is what it is. So what we need is a gradation. We need a gradation, whether it's a different model of Medicaid or it's something that's a bridge from Medicaid and HSA kind of a model. It needs to be something that can be paid into by state as well as by employers in a way that incentivizes people. And you can structure this. I really believe you can put some deliverables around this. You have to get an annual physical to be eligible for this. You have to adopt certain lifestyle changes in order to be eligible for this. There are certain ways that you have to meet certain metrics in order for this to be deliverable to you. But in that context, we're incentivizing good health, plus we're rewarding good health across the larger system. That kind of proactive thinking is, I think, our future.
So let me see if I can recap here, because I think we made some good ground. First, we think it is moral to profit from rendering services. We didn't talk about this earlier, but one could assert it's not a whole lot different from others in need, whether it's legal services or who are hurting from legal issues or financial services or any of a number of other things. But it's different because of human suffering is involved. And so we have a greater concern about this issue, and the morality issue, I think, surfaces in the form of directing payment mechanisms and business models for the industry. So I think we agree that we've come to an agreement that it is moral, and then that we've come to an agreement that you can't have a single solution. There's not one single delivery vehicle. Completely free market where there's an obligation to pay by everybody isn't going to work and by itself, and single payer isn't going to work is by itself. So we have to come up with ways to bridge to make sure that we get coverage to everyone. In other words, we need a greater availability and a greater obtainability, meaning is it available, and then can people afford it one way or another in our healthcare system. And then we need to drive towards over time, moving the application and the deployment of our resources to health as opposed to disease care.
I'm glad you said something about obtainability as well, because there is a vast spectrum of difference in our country relative to obtainability of care apart from the ability to pay. Rural communities simply just don't have the same health infrastructures as urban communities do. Certain parts of the country don't have as much available health care depending on the specialty of the issue as others do. At this point, telemedicine is becoming more and more an answer to the question. The ability for us to get diagnosed, the ability to get treatment, the ability to have nurse practitioners be more available to us, that sort of thing. Those are creative ways that we need to be looking toward obtainability as well as availability, as you said. And all of that has to be a multi-tiered structure. A quick example of that very quickly. A number of years ago, as you know, my oldest son was diagnosed with cancer, went through surgery and then 6 weeks of radiation. And by God's grace, we're so grateful to say that he gets an MRI every year. And so far, it's not recurred. And we're just so grateful for that. Well, one of the things I learned personally through that experience is something I knew intellectually before. There's no such thing as cancer. Cancer is a category. There's a actinic cell carcinoma, which is what he had, which is a completely different disease from one of the 10 categories of breast cancer, one of the 5 categories of colon cancer. Every cancer is a genetic mutation. And what you want to get to is the place where you can identify that specific mutation and treat that specific mutation. My friend Pete Dysart is chief of pathology at Baylor University Medical Center, and I do a lot of seminars together, conferences on medical ethics. He says right now we're treating cancer like we're carpet bombing. What we want to get to is the place where we're laser bombing. And we're going to get there. Genetic medicine is going to help us to get to that place. And that's going to be a breakthrough in everything we're talking about today as we get to that place. Well, I say all that just to say healthcare doesn't exist. It's a category. It has no ontological status, to use philosophical language. It's like leaves. Well, do you mean oak leaves or pecan leaves? What leaves do you have in mind here? So what we need is a stratified approach that is specific to regions of the country, to abilities to pay, to specific healthcare issues and metrics and all that's behind that. It's very complex, but that kind of whole of body thinking is what we're missing now. Right now, we're dealing with silos of individual treatment, of individual care providers and patients. This kind of holistic thinking you're bringing to the table, Todd, that comes back and asks, isn't there a holistic way of looking at this, is the key to the future, I believe.
Well, thank you for that. One of the things we're going to talk about in a future episode is the Center for Impact Indices, a company that I formed with Mary Hatcher, my partner, who in the Center for Impact Indices, we've developed the first ever healthcare inequality index that measures the distribution of healthcare services across the United States by health service area, kind of like a zip code with a hospital in the middle of it,
right.
And then measures availability and obtainability of healthcare services. Mm-hmm. And it's interesting because in our first pass at this, with just 2 dimensions, we found over 200 acutely underserved markets of over 150,000 people per market. So big swaths of healthcare deserts, if you will, where there's just usually nothing to buy for the people in those deserts. So there is another problem there that we have to address. Included in that is another thing we discussed in the book, which is the issue of the agrarian models for licensing. Mm-hmm. Disease doesn't really know geopolitical boundaries. So when you go across the state line, you're going to be still as sick as you were before you crossed it. And telehealth has all sorts of regulatory issues associated with it, which is why the insurance companies and the physicians are struggling to figure out good ways to implement it. But again, that's another topic for another day. But it's always such a blast with you, Jim, because there's so many things to talk about, and it's always such a good conversation. Today is nothing short of fantastic, and I'm so grateful for your time. I want to wrap it up there, and let's make sure that we've complied with our three guardrails of civil discourse. Hopefully we have. But thank you so much for your time today. Again, for everybody, Jim has a book out called Respectfully, I Disagree. It's, I think, number 20 or 21 or something like that in the series and in your publications. And he also has the daily blog from the Denison Forum. So I encourage everybody to look at that and to subscribe. You'll find a tremendous amount of wisdom expressed every day. Thank you, Jim, for your time today.
Todd, a great privilege. Thank you for your board service to our ministry. And thank you for your friendship over these years and the privilege that's been mine to be in the conversation today.
Thanks for watching this week's episode of Civil Discourse. To learn more about today's topic or our guest, visit www.the60percentsolution.com or www.tfip.group.